Hello, everyone. My name is Julie Depper. I am a physician assistant at Stanford Medicine Children's Health. I practice in the pediatric liver transplant department and have been here for about 10 years. I'm very excited to be presenting to you today about pediatric liver transplant and the postoperative care. The goals of this lecture are to give you some familiarity about what the post-transplant course looks like and to give you some understanding of how your child's course will progress through their hospital stay and give you some visibility as to things that your child may be experiencing and how you can best support them. Your hospital stay can look very different depending on your child and how ill they are. Your child will come out of the operating room initially and be transferred to the ICU, which is called the intensive care unit, for their initial postoperative care. They will remain in the ICU for an average of 3 to 5 days and then transfer to an acute care unit, which is somewhere within the hospital that requires less frequent monitoring. They will be discharged from the hospital on average between 7 to 14 days after their transplant. The total number of days can vary by the institution that you are at. It can vary by your child's needs and how their clinical course progresses. And it can also vary on the timing between the ICU and the acute care floors. The first 24 hours after transplant is a very busy time for many families and patients. It's a very noisy time. There's a lot of things going on, and there's a lot of new team members that you'll be being introduced to. So just keep that in mind and prepare yourself for that because it is a very busy time to be in the hospital. The postoperative period initially is within the ICU. Your child may come back from the operating room intubated, which means that they still have a breathing tube in place that's helping to support their breathing while they heal and recover from their surgery. You may see that your child has many central lines or IVs. Those are catheters that are in your veins and arteries, and those can be used for lab draws, to administer medications or fluids, or to administer nutrition. Those lines can be in your neck. They can also be in your child's groin or in their arms or extremities. Your child will be hooked up to a cardiorespiratory monitor, which are wires that are often on your chest, child's chest, that are hooked up to a screen for us to monitor their heart rate, their blood pressure, and their breathing rate. We will be frequently checking their vital signs as well, including their temperature as well, to see if they have any fevers. Your child may also come out of the operating room with a Foley catheter, and that is a catheter that's placed to monitor urination until your child is able to urinate on their own, either on a bedpan or to get up and out of bed to go to the bathroom. Other lines or drains that you may have, depending on the center after liver transplant, are a JP drain, called a Jackson-Pratt drain. It's a little bulb that comes outside of the abdomen, and some patients will have those, but not all patients, depending on the center. We use that JP, you can see it here on the left side of the screen, to monitor for signs of bleeding or bile leakage from your child's newly transplanted liver. Some centers also use a biliary catheter that is within your child's bile duct of the newly transplanted liver and then exits the abdomen and collects in a bag that you can see just here below. We can monitor the production of your child's new bile, the color, the quantity, and the consistency. And we at our center monitor that quite frequently. It should look like used motor oil. Any changes to the production of bile or the color of the bile will be something that your clinical team will notify you of and will discuss with you. Your wound care. So your child will have an abdominal incision across their abdomen. Depending on the center, everybody's incision looks different. Some incisions kind of look like a little bit like a rainbow across your child's abdomen. Some incisions are called a Mercedes-Benz, which looks like the sign that's on the front of a Mercedes-Benz, which is a vertical line followed by kind of a rainbow. And some children will have a hockey stick incision, which just looks like the side of a hockey stick at the very bottom. Every incision is different depending on what kind of transplant your child has, whether it's a full-size liver, a portion of a liver, or a living donation. And that's something that you can clarify with your transplant surgery team before you go to the operating room. The incision may have staples for closure, or it may have a layer of sutures with surgical glue to close the incision. Every center is different in how they approach incisional and wound care and what the incision actually looks like. So please be sure to clarify with your team before you go to the operating room. The incision needs to be kept clean and dry after transplant. You're not able to submerge that incision underwater, so no baths or swimming for about 3 months after the transplant. And that's to make sure that the incision doesn't open up. So we want it to be kept not in an area where it could be soaked or get saturated, because that can encourage that incision to open up. Your team will instruct you on proper bathing, wound care, and how to keep your child's incisions and lines clean and dry postoperatively. And that's a great question to ask the bedside nursing in the ICU and on the acute care floors about how to care for that incision. Nutrition after transplant. This is also something that can vary depending on what type of nutrition your child was taking before they came in for transplant, and also what their return of bowel function is after transplant as well. Some of the options include having a feeding tube. That is either a nasogastric tube, which is a tube that goes in through your nose and ends in the stomach to feed your child, or a gastric tube or a gastrojejunostomy tube. And those are tubes that are in the stomach that are used to feed your child. Again, great questions to ask before you go to transplant about what type of feeding regimen we anticipate going into the case. Another option for nutrition is IV nutrition. And so that's something called TPN, where your child will receive nutrition through an IV or central line. Some children are able to eat immediately after their transplant. So within 24 to 48 hours, they have return of bowel function, which is hearing bowel sounds in the abdomen, they're passing gas, or they have a bowel movement. And that is a sign that we are able to feed your child by mouth. It's also required that your child no longer has a breathing tube in place for them to eat by mouth, and that they're no longer significantly sedated so that they're able to sit up and safely eat. Any of these are options for the nutritional status of your child after transplant, and we will review these. Some common procedures after transplant. So in the initial postoperative period after a liver transplant, lots of different things can happen. And so it's good to have some visibility about what those things might entail. An abdominal ultrasound with Doppler is a way for us to look at your liver after the transplant and identify how the liver is being perfused, meaning how are the veins and the arteries that we connected for your child's new liver looking? Do they have good flow? Do they have any blood clots? Or do they have any signs of any areas of narrowing, which we also call stenosis? So an abdominal ultrasound with Doppler is something that's very frequently done at most transplant centers to look at your child's new graft. Another thing is removal of central lines, the breathing tube, and the Foley catheter, as well as removal of JP drains. The central lines, breathing tube, and Foley catheter all usually come out within the first 24 to 72 hours post-transplant. Removal of JP drains usually happens around 3 to 5 days post-transplant. And then capping of a biliary drain or removal of biliary drain can happen anywhere within 1 week to up to 3 months post-transplant. So it's a little bit of a different thing based on whether or not your child actually has a biliary drain. Other things that can occur are postoperative imaging. If there are any concerns post-transplant of bleeding or infection, your child may have chest x-ray or an abdominal x-ray or a CT scan or an MRI. So those are all different ways for us to image the abdomen or the chest to make sure that everything is looking good. So be prepared that those are possibilities. Another thing that we frequently do is a liver biopsy. For those of you who are not familiar with the liver biopsy, this is something that we use to check on the actual graft itself. So it's a percutaneous biopsy through the abdomen to check to see if your child has any signs of rejection post-transplant. Liver biopsies are relatively non-invasive, but they can be frequently done if there's any concerns for the function of the graft post-transplant. An additional thing that's not listed here is return to the operating room for any concerns for post-operative bleeding, bile leaks, or a blood clot in one of the blood vessels. This isn't frequently happening during the post-transplant period, but it is something that can happen. So it's something that I wanted to note here. There are times where your child will have a post-operative complication, which will require them to move back to the operating room, have their incision reopened, the situation addressed, and then they will be closed up again. It is not frequent, but it is something that can happen. So prepare yourself in case that is the case. The first week post-transplant. In the first week post-transplant, we do a lot of different things, and there's a lot of things going on. What does your day-to-day look like as a parent caring for a child in the immediate post-transplant period? We will monitor your child's lab work daily, sometimes more frequently. In the first 24 to 40 hours, we often monitor your child's labs anywhere from 4 times a day to 2 times a day to make sure that that graft that we implanted is working well and is not rejecting. We also will monitor your child's daily labs to monitor immunosuppression levels. So your child will be started on new medications to help suppress the immune system to prevent rejection. And so we frequently monitor those drug levels on a daily basis. We also will physically examine your child and look at their incision. We'll look at their abdomen to monitor for signs of distension. We'll listen to their heart and lungs to make sure there's no fluid collecting in the abdomen or in the lungs. And we will monitor their vital signs as well, their heart rate, their breathing rate, their blood pressure, and their temperature. We monitor their intake and output daily as well, which means how much are they taking in by mouth, how much are they getting in through IV medications or IV fluids, and how much are they urinating or stooling, or how much is coming out of the drains on a daily basis. We monitor their weight daily as well. Is it going up? Is it going down? And things that, or is it stable? So all of this information can be used to, with the addition of your feedback and how your child is feeling, to guide our care on a clinical basis. Next. Some common scenarios, clinical scenarios that we have in the post-transplant period. One is infection. We monitor for signs of infection by looking at vital signs and lab work. Some children may need a prolonged course of antibiotic post-transplant. Another concern that we have post-transplant is rejection. Some children have rejection of their new liver, and we monitor the liver enzymes and the immunosuppression levels, or may get a liver biopsy or an abdominal ultrasound to check on the liver graft health. Another scenario is bleeding. Some children are at risk for bleeding post-operatively or can develop anemia from frequent blood draws. Most children in the immediate post-transplant period are requiring some degree of blood transfusions and are on some anticoagulation medications that help thin your child's blood in order to make sure that the new vessels that we have used to implant into the liver do not clot off. Biliary complications. Some children develop some areas of narrowing in the immediate post-transplant period in the bile ducts that are feeding into the liver. We can identify concerns about biliary complications by monitoring your child's liver enzymes, by monitoring the bile drain that we have, and by also using imaging. If there's a concern, your clinical team may recommend further interventions. Fluid shifts. It's very common after your child has a transplant to have shift in the fluid that's in their abdomen. Some of that comes out in the JP drains, and some of that will can float up into the lungs, and you'll see some fluid in the lungs, and that's why we get chest x-rays. We often use our chest x-rays as well as our medications to help clear fluid from the body immediately after transplant. Your child's nutrition regimen may change, and your child may have new medications that they are on that have their own side effects that are new, especially immunosuppression medications. So keep that in mind and get familiar, and the clinical team will continue to guide you on those new medications that are started in the immediate post-transplant period. When will my child be ready for discharge? This is a great question that many patients and parents are asking on a regular basis. So when can we go home? Some things that need to happen in order for your child to be safely discharged from the hospital are they need to be able to eat and well and not with any vomiting or changes in bowel movements after transplant. They need to be able to tolerate their tube feeds or the feeds that they're receiving by mouth. They need to be able to be active and engage in the regular activities that they were doing post-transplant. So they're meeting with the physical therapist as well as with our occupational therapist to make sure that they're able to sit up, they're able to crawl, they're able to walk to the bathroom depending on the age of your child. They need to be off all IV medications. They need to have no concern for an active infection, and there needs to be no active concern for rejection of their transplanted liver. They also need to have stable liver tests. So we're monitoring the liver enzymes as well as immunosuppression and drug levels. How can you help prepare for discharge? So it's really important to facilitate a safe discharge that we do teaching prior to discharge. So you need to be able to understand your child's new medication regimen. You'll be meeting with our pharmacist and other members of our clinical team to receive teaching about the medications, how to administer them, and what are the side effects. You'll need to know the timing of the medication as well. The really important medications that you'll be learning about are your child's immunosuppression medications. Another important teaching point is understanding your child's lines, their incision and drain care as well. Another important teaching point will be understanding your child's nutrition regimen. You'll be meeting with a member of our dietary team who will help you troubleshoot feeding tubes and how to mix formula if your child is receiving formula, or guide you on safe foods for your child post-transplant. Another thing that you'll be doing is receiving caregiving instructional tips. We encourage our transplant center to do 24 to 48 hours of caregiving in the hospital environment with the support of our nursing team and your inpatient clinical team before the discharge day. We want you to get comfortable on understanding what does the day-to-day look like for you and your child before you go home. And ask questions. If you're not feeling comfortable, let the clinical team know. We're here to support you, and we want you to be successful in an outpatient environment and really get comfortable before you go home. The road to recovery. The road to recovery can be a long one. It can change on a day-to-day basis, and the timeline can really change. But here are some things that can help you prepare for that. Remember, the road to recovery is different for every child based on their age, based on their clinical progression during their post-transplant period, based on whether they've had any complications with their transplant. The need for advice and support from your transplant team will vary in the immediate weeks and months to come. And please ask questions and voice any concerns you may have about your child's health. It's really important to have patient and family participation. Compliance is necessary for your child's recovery and post-transplant life, and it's really important that we are able to engage with you as a clinical team in the both inpatient setting as well as the outpatient setting. Learn about when you will need to notify your clinical team of changes in your child's health. So once you're discharged, we will be following up with you at our center around 2 times per week for labs and clinic. And that follow-up time can mean that you're remaining locally for up to 6 to 8 weeks or maybe longer, where we're monitoring your child. It's important for us to understand what challenges you're facing at home with your child. And it's important for you to understand what are things that we would want to know about as your clinical team, or things that would bring you back to the hospital for additional imaging, lab work, etc. Our inpatient clinical team will review discharge instructions regarding how to care for all of these things and alert you, and things that we want you to alert us of when you come back. Meet your outpatient team of clinicians before you discharge. Here at our center, we do outpatient discharge teaching, and we do an introduction and meet with you before you leave. But if you're being transplanted at another center, make sure that you know your outpatient team, who to call and when. Understand the clinic and lab schedule as an outpatient, and make sure that we are able to support you as best as we can. If you have any questions, this was a lot of information that we covered here today in this road to recovery post-liver transplant. Please feel free to ask questions, put them in the chat, and make sure that you ask questions of your clinical team at your center as well. All of these things are really complicated, and we are here to support you in your journey with your child through transplant. Thank you so much for your time. Goodbye.